In this session, we'll be dealing with the gross anatomy of urinary bladder. Urinary bladder is a hollow viscera. It serves as a reservoir of urine. So in children, it is abdominopelvic because the pelvic cavity is small and the bladder neck is at the level of upper border of the pubic symphysis. In adults, when the bladder is empty, it is pelvic and the bladder neck is above the lower border of the pubic symphysis, or it will be at the level of lower border of pubic symphysis. In distended bladder, it becomes abdominopelvic. It ascends by displacing peritoneum from the posterior surface of the anterior abdominal wall. So you can see in the newborn, the neck of the bladder is at the level of upper border of the pubic symphysis. You can see this is the empty bladder in adult. You can see this is the distended bladder. You can see this is the procedure suprapubic cystotomy, which is being performed in the distended bladder. So when the bladder is empty, it is tetrahedral in shape. When it is distended, it is ovoid. Average capacity is 120 to 320 ml. Mean capacity is 220 ml. The sense of filling is felt when there is 100 to 150 ml of urine within the bladder cavity. First desire for micturition appears between 150 to 250 ml of urine. Then without discomfort, distension of bladder can be borne by the individuals up to 450 ml. That is average 250 to 450 ml. It depends on individuals. In newborn, it is 20 to 50 ml. The painful sensation will be felt once the accumulated urine volume is beyond 450 ml. So if the urine volume accumulated within the bladder is 800 ml and above, then the micturition is beyond voluntary control. The anatomical capacity of the bladder is the volume of urine just before the rupture of the bladder. It is approximately 1 liter or more. So first we will see the features of the empty bladder. It is tetrahedral in shape. It is having an apex, base also called as posterior inferior surface or fundus. There is a superior surface. There are two inferior lateral surfaces. There are four borders, one anterior, one posterior, and two lateral borders, and there is a neck. So this is the apex. This is the base. This is the posterior border. So these are the lateral borders. This is the superior surface. This will be the base or posterior surface. This will be the inferior lateral surface. This will be the neck of the bladder. You can see these are the two ureters, and this is the median umbilical ligament attached to the apex and the umbilicus. Apex directed forwards to the upper part of the pubic symphysis. Then median umbilical ligament is attached to it, which extends up to umbilicus. This is a remnant of the urachus, which is developed from allantois. Base, otherwise called posterior inferior surface or fundus, triangular, directed backwards and downwards. It is non-peritoneal. In male, upper part is covered with peritoneum up to upper end of seminal vesicles. Non-peritoneal area is known as external trigone. So non-peritoneal area of base is known as external trigone. Relations of base in males: ampulla of rectum separated by rectovesical pouch, a pair of seminal vesicles, ampulla of vas deferens passing medial to vesicles, then rectovesical fascia, which is derived from the fusion of primitive rectovesical pouch of peritoneum. This is the Denon-Weyler's fascia. You can see here, this is the rectovesical fascia, Denon-Weyler's fascia. This is the ampulla of rectum. These are the seminal vesicles. This is the vas deferens. Relations of the base in case of male. In female, upper part of the anterovaginal wall, anterior surface of the supravaginal part of the cervix, and it is separated from the base of the bladder by loose areolar tissue. Anterior wall of the vagina, supravaginal part of the cervix, separated by loose areolar tissue. Superior surface is triangular and covered with peritoneum, sigmoid colon, coils of small intestine, and females anterior surface of the antevated uterus. You can see here, in females, anterior surface of the antevated uterus is also related to the superior surface of the bladder. Inferior lateral surfaces, they are directed downwards and laterally. They are non-peritoneal. They are related to pelvic surface of the body of the pubis and pubic symphysis, and fascia covering levator ani and apparate internus muscle. So between the inferior lateral surface and these two structures, that is the pelvic surface of body of pubis and pubic symphysis, and fascia covering levator ani and apparate internus muscle, there is a space, horseshoe-shaped space called retropubic space of Ritzius, which contains retropubic fat and plexus of vesical veins. So space of Ritzius, it acts as a bursa to allow bladder distension. It is horseshoe-shaped space between anterolateral pelvic wall and sides of bladder and prostate. In front, it is bounded by symphysis and body of pubis. Behind and on each side, posterior true ligament of bladder. I will tell you in further slides what is posterior true ligament of bladder. And above it is the peritoneum of the paravesical fossa. Below it is the pubovesical or puboprostatic ligaments and reflection of pelvic fascia from parietal to visceral layer, that is from lateral pelvic wall to the bladder. Medially, inferior lateral surface of the bladder and prostate. Laterally, it is the fascia covering levator ani and obturator internus muscle. The contents are retropubic fat, vesicle plexus of veins. So, what is the importance here? The surgical approach to bladder and prostate can be achieved retroperitoneally through this space if the bladder is distended, like I have shown in the earlier diagram where we were doing suprapubic cystotomy. So, you can see here, this is the space of Ridges. You can see above bounded by the paravesical foci. Paravesical foci. So, this will be the levator ani, and this is the obturator internus. You can see laterally this is bounded by the fascia covering obturator internus and levator ani. So, medial it is the inferior lateral surface of the bladder and prostate. Features: anterior border extends from apex to the neck of the bladder. I have shown in the earlier diagrams. You can see here. Anterior border extends from apex to the neck. Posterior border extends between the two ureters. Lateral border extends from entry of ureter to the apex. And this anterior border separates two inferior lateral surfaces, whereas the lateral border separates the superior surface from inferior lateral surfaces. The posterior border separates the superior surface from the posterior inferior surface of the base. Anterior border extends from apex to neck, separates inferior lateral surfaces. Posterior border between entrance of ureters, separates superior surface from base. Lateral borders to apex to entrance of ureter, separates inferior lateral surface from the superior surface. So there are two inferior lateral surfaces and there are two lateral borders. Neck, it is the lowest point from which urethra begins, 3 to 4 centimeters behind lower border of the pubic symphysis. This is a normal adult position. In male, surrounded by prostate. In females, lies at lower level, comes in contact with the superior fascia of urogenital diaphragm. Physiologically, the neck is considered in such a way that in males, prostatic urethra is included in the neck. In females, entire urethra is included in the neck of the bladder. Physiologically, okay, remember, not anatomically, physiologically. Reason: because detrusor muscle extends up to this level in males as well as in females. In males, it extends up to the prostatic urethra. In females, it extends entire urethra. So that's why physiologically, the neck of the bladder includes prostatic urethra in male and entire urethra in female. External features in distended bladder. Distended bladder is ovoid. There is anterior-inferior surface, and there is posterior-superior surface, and there are two lateral surfaces. There will be a summit, and base and neck are constant. You can see here, anterior-inferior surface is non-peritoneal, extends above symphysis pubis by displacing peritoneum from posterior surface of the anterior abdominal wall. Then posterior-superior surface covered with peritoneum. The sigmoid colon, coils of small intestine, and uterus is related in case of females. Lateral surface, it is partly peritoneal and partly non-peritoneal. And the summit, it is lying behind the apex. Prevesical pouch of peritoneum separates it from the anterior abdominal wall. Base and neck, these are fixed and correspond with the empty bladder. You can see here. This is the summit. This is the apex. This is the summit separated by prevesical fossa. So this is the lateral surface what we are seeing. This is the posterior superior surface. This is the antero inferior surface. The base and neck are constant. There are no borders when the bladder is distended. Ligaments, true ligaments, total 9 in number. You can see here. Median umbilical ligament, which is a remnant of urachus developed from allantois, extends from apex to umbilicus. Puboprostatic ligaments in male or pubovesical ligaments in female. These are 4, 2 on each side. The medial puboprostatic ligament extends from neck of the bladder to the pubic symphysis, and the lateral one extends from neck of the bladder to the anterior end of the tendinous arch of pelvic fascia. Lateral ligaments, 1 on each side. They extend as sheet from inferior lateral surface of the bladder to the tendinous arch of the pelvic fascia. Posterior true ligaments, these also extend as a sheet from side of the base of the bladder to lateral pelvic wall. So this contains the plexus of vesical veins. So through these veins, the venous blood is drained into the internal iliac vein. So it blends medially with the rectovesical fascia. So posterior true ligaments, they extend as a sheet from side of the base of the bladder to the lateral pelvic wall. They contain plexus of vesical veins and blends medially with the rectovesical fascia. False ligaments, these are the peritoneal folds which are 7 in number. Anteriorly there are 3. The median umbilical fold covering the median umbilical ligament and a pair of medial umbilical folds covering the obliterated umbilical artery. So between these two folds is the supravesical fossa. Laterally, a pair of lateral false ligaments, they extend from bladder to the lateral pelvic wall, forms the floor of the paravesical fossa, which I have shown earlier. This peritoneum of the paravesical fossa forms the superior boundary of the space of Ritzius. Posteriorly, a pair of sacrogenital folds, which extends from lateral angles of the base of the bladder to the third sacral vertebrae. So if you see here, posterior true ligaments, they extend as a sheet from side of the base of the bladder to the lateral pelvic wall, which contains plexus of vesical veins. Whereas this posterior false ligament, these are a pair of sacrogenital folds which extends from just lateral angles of the base of the bladder to the third sacral vertebrae. So if you see the peritoneal fossa surrounding empty urinary bladder, there will be a pair of supravesical fossa anteriorly and a pair of paravesical fossa laterally and one rectovesical fossa posteriorly in case of male or utrovesical fossa in case of female. Total 5. So total there are 9 true ligaments, 7 false ligaments are peritoneal folds and 5 fossae surrounding the urinary bladder. Peritoneal fossa surrounding the urinary bladder. A pair of supravesical, a pair of paravesical and one rectovesical fossa in case of male or utrovesical fossa in case of female. You can see here, this is the median umbilical ligament covering the urachus. This is the medial umbilical ligament. This is the lateral umbilical ligament. This is inferior epigastric artery and vein. This is oblatory umbilical artery. This is the urachus. So this is the supravesical fossa. Then this will be the medial inguinal fossa. This will be the lateral inguinal fossa. Here you can see this is the paravesical fossa. Here you can see this is the median umbilical ligament. These are the puboprostatic ligaments in case of male or pubovesical ligaments in female. This is the lateral ligament of the bladder. This is the posterior true ligament of the bladder. You can see this is the rectovesical pouch. You can also see this is the rectovesical fascia of Denonvilliers. You can see this is the base of the bladder separated from ampulla of rectum by the seminal vesicles, the ampulla of the vas deferens and the rectovesical fascia of Denonvilliers. Here you can see this is the pubovesical ligament where the neck is directly related to the superior fascia of urogenital diaphragm in case of female. Here you can see the neck surrounded by the prostate and these are the puboprostatic ligaments. Bladder bed. The urinary bladder rests on the following structures, namely the pubic symphysis and body of pubis anteriorly, fascia of levator ani and reptile internus muscle laterally. You can see here. So fascia of levator ani and reptile internus laterally. And retropubic fat within the retropubic space of Ritzius, ampulla of rectum posteriorly in case of male or anterior wall of the vagina in case of female, base of the prostate in male and superior fascia of urogenital diaphragm in case of urogenital diaphragm in case of female and prostate in case of male. Structure. So microscopic structure covered by serosa peritoneum which is incomplete, muscular coat also called a detrusor muscle. It is having outer longitudinal, middle circular and inner longitudinal, but clear demarcation is not seen. Everything will be going haphazardly in all directions. Outer longitudinal layer continues with the muscle of the prostate. Few fibers extends to pubic bone as pubovesicalis and to the longitudinal muscle of the rectum as rectovesicalis. Keeps the bladder in position. The middle circular layer thickened around internal urethral orifice as sphincter vesicae. So it present all around, but it thickens around the internal urethral orifice as sphincter vesicae, which is involuntary. Then inner longitudinal layer continues with the muscles of the urethra. So close to the internal urethral orifice, these detrusor muscle fibers form series of U loops which are present in front and behind the urethra. So in male, there will be a complete circular collar or smooth muscle surrounding bladder neck and supplied by sympathetic fibers, prevents reflux of semen during ejaculation. In female, no smooth muscle sphincter at bladder neck. Detrusor muscle extends up to prostatic urethra in male and entire urethra in female. You can see here these are the U-shaped loops which are present in front and behind. You can see this is the pubovesicalis muscle, this is the rectovesicalis muscle. The trigonal muscle of the ureter is separated from the detrusor muscle by fascia of Wilder. It is present in the internal trigone. I will speak about it in further slides. The contraction of the trigonal muscle pulls up a mucosal fold which further narrows the internal urethral orifice. The submucosa, it is the loop tissue. It is absent at trigonum vesicae. So here mucosa is attached to the underlying muscle. The mucosa is actually devoid of muscularis mucosa. So submucosa is in fact the lamina propria of the mucosa. So some authors consider that submucosa is absent in entire urinary bladder. The mucosa, it is having transitional epithelium or urothelium, which is urine proof. There are no mucosal glands or no muscularis mucosa. Few mucosal glands known as subtrigonal or subcervical glands detected close to internal urethral orifice. The urothelium, it is polyhedral cells. They have abundant cytoplasm, prominent nuclei, and few cells also show polyploid number of chromosomes within the nuclei, and these cells are connected by tight junctions. The cytoplasm spreads like umbrella during bladder restriction without giving tension to the individual cells, hence called umbrella cells. So this is the internal trigone of bladder. You can see the internal urethral orifice, the two ureteric orifices, all these three, they united by equilateral triangular area. So this is the internal trigone of bladder, and connecting these two in ureteric orifices is the interureteric ridge, also called as Mercier's bar, and between the internal urethral orifice and ureteric orifice, this is called as Bell's bar. Mercier's bar and Bell's bar. This is the internal trigone. You can see this is the uvula of the bladder. So you can observe everywhere there are mucosal folds, but here there are no mucosal folds. So there are temporary mucosal folds or rugae present all over the interior of the bladder except trigonum vesicae. The trigone, internal trigone, it's an equilateral triangle, which is the inner aspect of the base of the bladder. The mucous membrane is tense and glistening due to absence of submucous coat. The apex of this trigone is formed by the internal urethral orifice. It is crescent shaped. In males, uvula vesicae, a round elevation projects behind the urethral orifice, which is formed by the median lobe of prostate. If this lobe is enlarged, it will cause difficulty in micturition. Then base is formed by the interureteric ridge, which is called Mercier's bar. It extends between the two ureteric orifices. The transverse ridge is slightly curved, formed by prolongation of the inner longitudinal muscle of the ureters. Posterolateral angles, the ureteric orifices, these are seen as oblique slits. Usually in empty bladder they are 2.5 centimeters apart. In distended bladder they will be 5 centimeters apart. Ureteric fold of mucous membrane extends from ureteric orifice upwards and laterally, and this indicates the intravascular course of the ureter. So from here this extends like this, which represents the intravascular course of the ureters. The sides of the trigone, uretero-ureteric lines, these are called as Bell's bar. So this is the Mercier's bar, this is the Bell's bar. Structure of the trigone, there will be mucosa, there will be no lamina propria. So directly mucosa is attached to the trigonal muscle of Bell, and there will be fascia of Waldeyer separating the trigonal muscle of Bell from the detrusor muscle. Most fixed and dependent part of the urinary bladder, which acts as a surgical landmark for the urologist. Richly supplied with blood vessels and nerves. Interior of the urinary bladder developed from mesoderm by incorporation of caudal parts of the mesonephric ducts, whereas the rest of the bladder mucosa is developed from endoderm of the cloaca. That means this particular trigone, internal trigone or the trigonum vesicae is developed from the mesoderm by incorporation of the caudal parts of the mesonephric duct. That is how this trigonum vesicae is different from the rest of the bladder mucosa, which is developed from the endoderm of the cloaca. So in male, uvula vesicae enlarged in old age and obstruct urine flow. Okay, bulges within the sphincter vesicae. This also affects the sphincter control. Okay, internal urethral sphincter control. So urine trickles down the proximal urethra, and there will be frequency of micturition. So this uvula vesicae, which is formed by the median lobe of the prostate, due to enlargement of prostate. So this will be enlarged, and it will affect with the sphincter mechanism of the internal urethral sphincter, so that there will be trickling of urine in the proximal urethra, which will result in frequency of micturition. The Mercier bar, which is a pale band, this acts as a surgical landmark, helps identifying ureteric orifices in cystoscopy for the urologist. And if you observe, due to tuberculosis of kidney, there will be shortening of the ureter, resulting in change in the shape of the ureteric orifice from an oblique slit to a oval orifice. So that is called as Gulf hole ureter. So arterial supply of urinary bladder. The superior vesical artery, which is the non-obliterated part of the umbilical artery, it's a branch of internal iliac artery. So this is for your next entrance. The superior vesical artery is the non-obliterated part of the umbilical artery. Then inferior vesical artery, it's a branch of internal iliac artery. This will be replaced by vaginal artery in case of female, and there will be obturator artery which will also supply the urinary bladder. In female, there is an additional uterine artery which will be supplying the urinary bladder. So veins, vesical plexus, which are present in the inferior lateral surface in the space of ridges. In male, they also communicate below with the prostatic venous plexus. Finally, they drain into the internal iliac vein through posterior ligament of bladder. Finally, drains into internal iliac vein. Through posterior ligament of bladder. That's what, no? Through true posterior ligament of bladder, the vesical venous plexus will travel and drain into the internal iliac vein. Lymphatic drainage, they drain into external iliac lymph nodes, but for descriptive purpose, you can see the apex and inferior lateral surface drain into anterior group of external iliac nodes. The upper surface drains into intermediate group of external iliac nodes, whereas the posterior surface drains into the posterior group of external iliac nodes. Nerve supply of urinary bladder, sympathetic, motor and sensory. Parasympathetic, they also have motor and sensory fibers. The motor fibers comes from T11 to L2 superior. So these are the preganglionic fibers coming from T11 to L2 segments. They reach the postganglionic cells which are present in the superior hypogastric plexus. From there, the postganglionic neurons or the axons come out as right and left hypogastric nerves. They pass on either side of the rectum and reach the bladder. They stimulate sphincter vesica and inhibits detrusor muscle. They help in filling of the bladder. So we call it as nerve of filling of bladder. The sensory sympathetic fibers, the cell body is located in dorsal root ganglia of T11, L2 spinal nerves. They carry the pain sensations from bladder which are other than due to distension of the bladder. The distension of the bladder sensation will be carried by the parasympathetic sensory fibers. So parasympathetic fibers, they also have motor and sensory. So it is S2, S3, S4 segments from which comes the pelvic splanchnic nerves, otherwise called nervii regentis. They supply the detrusor muscle. So stimulation of this contracts the detrusor muscle, and they also supply the proximal urethra. The damage results in urine retention and overflow incontinence. So damage to this parasympathetic motor supply will completely inactivate the detrusor muscle. So there will be dilatation of the bladder without contraction, and there will be overflow incontinence. Parasympathetic sensory fibers, the sense of distension and some painful sensations. Their cell bodies are located in the dorsal root ganglia of the S2, S3, S4 spinal nerves. The damage results in loss of sense of distension. So normal act of micturition is mainly under control of the parasympathetic fibers. Control of parasympathetic fibers. Now, so we have to deal in detail about this nerve supply, bladder, loop mechanisms and all those things. I will take some time to describe this. So first is consciousness of bladder sensation. The sense of distension, it passes successively through, if you observe here, these are the sensory fibers. If you observe, it is passing successively through the ipsilateral tract of gall, that is fasciculus gracilis, to the nucleus gracilis, then the internal arcate fibers and medial lemniscus, then to the posterior part of the paracentral lobule through the thalamus. You can observe here the sensations from here, sense of distension passing through this parasympathetic sensory fibers, then tract of gall, nucleus gracilis. So tract of gall is nothing but the fasciculus gracilis, nucleus gracilis, internal arcate fibers and medial lemniscus to the thalamus, and then to the posterior part of the paracentral lobule. The pain sensation, it reaches the posterior horn of the spinal cord. Pain sensation, it reaches the posterior horn of the spinal cord. Here you can see this is the pain sensation reaching the posterior horn of the spinal cord. Okay. Then what happens? Here also the pain sensation is reaching the posterior horn of the spinal cord. So sympathetics also carrying the pain fibers, parasympathetic also carrying the pain fibers other than distension. Now from here what is happening? They pass successively through contralateral lateral spinothalamic tract. Contralateral lateral spinothalamic tract. You can see here, this is the lateral spinothalamic tract. It is going to the thalamus. So earlier the sensations of distension are passing through the fasciculus gracilis or tract of gall, then nucleus gracilis, internal arcate fibers, medial lemniscus, thalamus, and to the paracentral lobule. Here the pain sensations from both the sympathetic as well as from the parasympathetic, they are passing through the contralateral lateral spinothalamic tract, and spinoreticular tracts. Here you can see there is some collaterals given to the reticular formation. So spinothalamic as well as spinoreticular, contralateral. So pain sensations are going on the opposite side, whereas distension of bladder is going on the same side. Clear? So then from here thalamus, again they will go to the paracentral lobule. Okay. Then paracentral lobule is concerned with perception of fullness of bladder and desire to void urine. So these pain sensations are given both to the brainstem micturition center as well as to the paracentral lobule. Brainstem micturition center as well as to the paracentral lobule. Then, reflex control of micturition. So, there are three reflex controls, namely the motor area of the paracentral lobule. You can see here, this is the motor area of the paracentral lobule, and detrusor center in the pons. You can see here, this will be the detrusor center in the pons. This particular one, detrusor center in the pons. Then sacral micturition center. Here you can see this is the sacral micturition center. So paracentral lobule, then detrusor center in the pons, and the sacral micturition center, which is S2, S3, S4. Okay. So three loops of neurons are there. This is the loop 1, this is loop 2, and this will be the loop 3. So now loop 1, if you observe here, the loop 1 also called as cortico-reticular. Cortico-reticular. So from cerebral cortex to the reticular formation in the brainstem, it links this particular detrusor center to the paracentral lobule both by afferent and efferent limbs, which pass parasagittally on each side of the lateral ventricle. Parasagittally on each side of the lateral ventricle. So if you observe in children, due to loss of cortical center control on detrusor center during sleep, so children less than 5 years, so they usually can't regulate the threshold of tone of the bladder, and they can't adapt the detrusor muscle for that tone. So this will result in nocturnal enuresis. This will result in nocturnal enuresis because this cortical control over the detrusor center is not well established in children, which is resulting in nocturnal enuresis during sleep. Then the loop 2 is the reticulosacral loop. Reticulosacral loop. So it connects detrusor center with the sacral micturition center. Again same by ascending and descending fibers. So upper motor neurons from the pyramidal and extrapyramidal tracts usually inhibit later horn cells of the S2, S3, S4 segments, except in children up to 3 years. So until suitable space and time are available for voiding urine. Okay. So this upper motor neurons will inhibit this sacral micturition center, except in children up to 3 years. Until the time and space are available, it will be inhibiting the sacral micturition center. Sometimes this upper motor neuron stimulate the sacral micturition center even when there is no desire, and sometimes they will stop micturition in the midstream, okay, by voluntary contraction of perineal muscles. So this actually they inhibit, then they stimulate even when it is not necessary, and sometimes during micturition also they can stop the urine voiding in the middle of the micturition by contracting the perineal muscles. So this much control is borne by the upper motor neurons. Now coming to the last center, that is S2, S3, S4, that is the sacrovesical loop or the sacral micturition center, that is a loop 3. So it connects this sacral micturition center to the bladder wall by sensory and motor components, mainly by the pelvic splanchnic nerves. So it is mainly concerned with two reflex acts. The stretch receptors from the bladder are initially stimulated as the bladder distends, and the impulses therefrom are relayed to the later horn cells of the S2, S3, S4 segments. You can see here. So this stretch receptors carrying distance and sensation to the S2, S3, S4 segments. On appropriate stimulation, this detrusor muscle will contract. You can see this motor fibers, parasympathetic motor fibers which are coming here, they will stimulate the detrusor muscle for contraction for passing urine. So when the detrusor muscle contracts, the bladder neck will dilate. The bladder neck will dilate and urine appears in the proximal urethra. Urine appears in the proximal urethra. The stretching of proximal urethra will initiate second reflex again through the spinal cord via the pelvic splanchnic nerves, and ultimately you can see here the lower motor neurons from the anterior horn cells, from the sacral segments, they will result in dilatation of the sphincter urethrae, which is an external voluntary sphincter for supporting the act of micturition. So initially distension of bladder, then contraction of detrusor muscle, then dilatation of the urethra, then perception of the same thing by the S2 S3 S4 segments, then anterior horn cells of the S2 S3 S4 segments through pudendal nerve. So they are going to dilate the voluntary sphincter, that is the sphincter urethrae muscle, which is a voluntary muscle, that is the external urethral sphincter, and completes the act of micturition. This is how three different loops are controlling the act of micturition. Here you can observe through positron emission tomography scan, you can see this is the sacral micturition center, which is lying at S2 to S4 segments. You can see here within the pons, there is an M center for voiding and there is a L center for storage. And if you go still higher, so there are so many things like periaqueductal gray matter, then ventral posterior nucleus of thalamus, the pre-optic nucleus of hypothalamus, the inferior frontal gyrus, an anterior cingulate cortex connected to the paracentral lobule on the right side. So all these are playing the role of higher control in controlling the act of micturition. So now, after understanding all these loops, let us study the few neurological disorders of urinary bladder. The first one is reflex bladder. So after transection of the spinal cord above the sacral micturition center, that is above S2, these are the loop 2 neurons. That is somewhat like upper motor neuron lesion. So initially all reflexes are lost and the bladder becomes atonic. There will be over distended bladder with overflow incontinence. But after some time, within few weeks, the micturition reflex returns and there is no control of this micturition reflex, which results in this reflex automatic bladder, otherwise called as spastic neurogenic bladder, in which you can observe there will be bladder which is hypertrophied with residual urine. It is mainly due to loop 2 neurons. The next condition is atonic bladder, which is mainly due to damage to the afferent limb of the loop 3 neurons, that is the parasympathetic sensory fibers. So what is happening? The bladder is distended, thin walled and hypotonic, and there will be overflow incontinence. This is due to damage to the parasympathetic sensory fibers, which is observed in certain conditions like tabes dorsalis. So this is due to dorsal column and nerve root degeneration due to syphilis. So parasympathetic sensory fibers, which are carrying the sense of distinction, is damaged. So the person cannot feel that the bladder is distended. So bladder keeps on distending and there will be overflow incontinence. The third condition is autonomous bladder. So here both the afferent and deferent limbs of the loop 3 are destroyed in certain pelvic surgeries or in some tumors of cauda equina. So the bladder becomes small and hypertrophied. Definitely there will be incontinence. So these patients might need a catheter. Then the last but not least, the uninhibited bladder. It is mainly due to damage to the loop 1 neurons. So this results in urge incontinence, in which there is sudden uncontrolled evacuation with no residual urine. So this results from lesions affecting frontal lobe or parameningiomas or aneurysm of the anterior communicating artery, which supplies the important micturition center areas in the higher centers. So loop 1 between paracentral lobule and detrusor center in the pons, loop 2 between the detrusor center in the pons and the sacral micturition center, that is loop 3. So loop 3 is between the sacral micturition center and the bladder. So these three loops plays a significant role. And in recent studies after PET scan, so we have found so many higher centers concerned with the micturition. Not only the paracentral lobule, there are additional centers like inferior frontal gyrus, anterior cingulate cortex, preoptic nucleus of hypothalamus, the ventral posterior nucleus of thalamus, periaqueductal gray matter. All these are activated. These are actively activated during micturition, and mainly the right side of the cerebral hemisphere is controlling the act of micturition. And here in the pons, there is L center, which is for storage. You can see the cell center, anterior horn cells. They are actually controlling the sphincter urethrae. So this is called as Onuf's nucleus, excitatory neuron. And here you can see the M center, which is inhibiting this Onuf's nucleus, so that this will actually dilate. This will actually dilate for micturition. So there is L center for storage, which is contracting the sphincter urethrae, and there is M center, which is for voiding, which will relax the sphincter urethrae. Okay, and this is the sacral micturition center. All these areas were active during the PET scan on the right side when the micturition was taking place. This is how these areas were identified. Thank you.